fibrillation, sometimes that mitral leakage can also improve. A lot of the risk factors you've been discussing already, hypertension, obesity, diabetes, alcohol use, all of these are significant players in the evolution of atrial fibrillation. And of late, we increasingly recognize the role of obstructive sleep apnea. So it's pretty much a routine for us now to recommend screening for sleep apnea. And I've been quite surprised that a lot of people who you don't think have the physical habitus that you would associate with sleep apnea, and yet when we test for it, it turns out that they do.
Could you say a little bit more about the association and how that works?
Between sleep apnea?
Sleep apnea and atrial fibrillation.
Yeah, well, sleep apnea is associated with a lot of things, that not just atrial fibrillation, but other cardiac arrhythmias and sudden death and so on. And I think it's just got to do with the fact that when you have apnea, you become hypoxic, and hypoxic triggers a various number of factors in the atrial tissue that lead to atrial dilatation, changes in the cellular structure, and so on. I mean, that's probably speculative, but the reality is the clinical observation of the association, and the second reality is that effective treatment seems to reverse the process. Of course, the most effective treatment for sleep apnea is weight loss. So when we talk about atrial fibrillation, we describe it initially as paroxysmal, which means it comes and goes of its own volition. This is the way it typically starts. But over time, if we haven't intervened, the atrial fibrillation becomes persistent. That means it's staying there all the time unless we do something about it. And the something we can do about it is to maybe shock the heart or give people drugs or what have you, and that gets them back into rhythm. But ultimately, if nothing is done, the atrial fibrillation can become permanent. It's there as a fixed entity. And this is the case in a lot of elderly patients in particular, and it creates a situation for us, well, how aggressively do we treat these? Back in the early part of this century, there's kind of two dual approaches to atrial fibrillation. One is called rate control, and the other is called rhythm control. Rate control means essentially that you accept the fact of atrial fibrillation, you focus on stroke reduction issues, which I will discuss presently, and you make sure that the heart rate doesn't go too fast. So it's a fairly simple strategy. The alternative is to do something called rhythm control. That's where we do everything in our power to restore people to sinus rhythm, and I'll talk about some of the techniques we have for that. But when you're dealing with an older population, many of whom are not really symptomatic with this atrial fibrillation, we have done studies to compare outcomes. Which is the better strategy? To control the rate and anticoagulate, or to do everything we can to put people back in rhythm? The rhythm controls.
Can you say that a little bit more loudly and slowly?
Sorry. I don't know how to talk slowly, but I'll do my best. All right, so we have two main ways of treating atrial fibrillation. This is kind of an aside from my main topic, but one of them is called rate control. In the rate control, we say, okay, you have atrial fibrillation. We want you to live with the atrial fibrillation because we think that the process of trying to get you out of it is just not worth it or likely to be successful. That's called rate control. The other strategy is we have lots of things we can do. Surgery, ablation, drugs, all of which I'm going to present in a few moments. We can do all those things and try and put you back in rhythm. So the question arises as which of these strategies should you pursue? And what I wanted to talk about was the fact that in the early part of this century, there were about 10 studies done, and we were participants in the biggest of these, called the AFFIRM trial, to compare these two strategies. These strategies really only apply for the older population that don't feel their atrial fibrillation. We call these asymptomatic patients. But it turned out when we measured the things that really matter, which are survival, how many people died, and the incidence of stroke, there was no significant difference. So many times, when we are dealing with an older, asymptomatic patient, our decision process is relatively easy. We are going to say, the main focus here is ensuring that we are reducing the risk of stroke. And that means, by and large, taking anticoagulant medication. But that doesn't mean that you won't treat the people who are symptomatic, who are bothered by the atrial fibrillation, who are having the symptoms I discussed previously. The information does not apply either to the younger people that were not tested in those studies. So for younger folks or people who are symptomatic, have these palpitations, have the shortness of breath, have the fatigue, then we will take a more aggressive posture. This is a complicated slide, and it has to do with the various mechanisms that we believe underlie atrial fibrillation. And we think these mechanisms evolve over time. So the current thinking is that at the beginning, when the atrial fibrillation is still paroxysmal, it may be due to a single or a few reactive sites in the atrium that are triggering these signals. However, over time, the constant bombardment of these signals leads to a change in the electrical properties of the atrium itself, and that creates a situation where multiple circuits may evolve. And then ultimately, when it becomes permanent, there's even more circuits present. And this information actually leads to variations in the treatment strategies, depending on where we are in the cycle. Before I want to get into that, the question comes up, well, how do we diagnose atrial fibrillation in general, or how do we screen for it? How do we evaluate patients in whom we think there may be a risk of this occurring? And there are a variety of tools available. The standard EKG that we do in the office, but remember that's a 10-second snapshot in time. And I told you the atrial fibrillation may be paroxysmal, it may come and go. So it's perfectly plausible for people to come in, tell you they have these symptoms, and yet we're unable to find it just on the basis of looking at an EKG. Probably the most well-established technology is the 24-hour Holter monitor. I'm sure you've all heard of this. This thing is applied with patches. It's hooked up to a little battery pack that sits on your belt level, and it monitors every single beat for 24 hours, which is fine as long as you have symptoms within that 24-hour period. I mean, I can't tell you the number of times that people come into me and tell me, oh yes, but as soon as you took it off, I had a problem, right? It happens. And that has led to the evolution of event recorder devices, and where we can monitor for longer than 24 hours, maybe up to 2 weeks or so. And we also have these implantable devices now that have a very important role, and actually Shelley, who is my research coordinator, is going to show you some of these devices and pass them around. This is one of the newest toys on the deck. It's called a Link device. It's a little plug that can be injected under the skin. It's not unlike a little chip that you would put in a pet to locate them, right? But this is an EKG machine that lasts for 3 years. It is particularly useful, I think, for patients who present with a stroke and have no apparent reason for it, so-called cryptogenic stroke. Because as I pointed out earlier, a lot of these patients do have atrial fibrillation that has not been detected. And of course, if we have atrial fibrillation and we have a stroke, we know we need to recommend anticoagulants. However, anticoagulants are not entirely benign, so we don't want to recommend them unnecessarily. So that little device called the Link device, very easy to insert, about a 10-second procedure, can be useful in that population of patients. Another new development is these transcutaneous patches. A lot of people don't like the notion of being hooked up to these wires and having the wires in their belt or so on. And there are a couple of companies now that manufacture these things that are basically USB ports attached to a Band-Aid. You stick it on the skin, you can bathe or shower with the thing in place, or you can swim with the thing in place, and that will accumulate information every single beat for a week, 2 weeks, or however long you program it. And when the patient is done with it, they simply put it in an envelope, send it off to the processing center, and we go online and look at the reports presently. Very, very useful, simple ways of diagnosing these arrhythmias. A very commonly used gadget now is this app on the phone called the AliveCor app. Very, very simple technique, very, very useful. You get this little metal plate at the back of the phone, put your fingers on it, and it records an EKG of the quality you see on this screen. Now, the limitation, of course, is you're not likely to take it out if you don't have any symptoms. However, if you do have symptoms, it's very, very useful, because we often contend with the worried well. And what do the worried well do when they feel symptoms? Well, they go to the doctor, they go to the emergency room. The rule used to be, you showed up 4 times with the same symptom and we find nothing, you go to the psychiatrist. But in fact, many people do have symptoms, and it's because we just simply have not had the ability to make the diagnosis. So I'll just give you a practical example of how this has worked for me. I was back at a meeting on the East Coast, and one of my patients was vacationing in Mexico, felt symptoms come on, had this device, was able to make a recording of his rhythm, and send it to me by text message, and we could reassure him, hey, there's nothing wrong. saves them a trip to the hospital. I think it's a very, very useful technology, and I'm a big fan of this device. And it's very inexpensive, by the way. I think it costs about $75. The app is free, and it's yours forever. As an aside, some of the patients whom I've given this to have made diagnosis on their friends, which has generated more business. All right, so the tripod of treatment of atrial fibrillation is as listed. The main things we focus on are anticoagulation and rhythm control and rate control, which we talked about. So as far as rhythm control is concerned, well, this is just a list of options, basically, so let me just move along here. As far as rhythm control is concerned, the first line typically will be medication. Now, none of our medications are like free lunches, you know, every single one of them has potential downsides. So we have to be careful about which medication we pick for which patient. And our current data suggests that for people who have little or no heart disease, we can use pretty much any of these drugs. But for people who have significant blood pressure issues, we need to be careful. If the blood pressure has already done damage to the heart, then some of these other drugs can actually be quite dangerous. If people have no coronary artery disease, and remember a lot of these disease processes interact, people are affected by more than one, then you've got to be careful as well, because some of the drugs can be counterproductive. For instance, flecainide and propafenone may actually increase mortality. A lot of these drugs tend to weaken the heart muscle, so that if you have heart failure, you've got to be careful about which ones you will use. So all this comes into the decision process regarding which treatment strategy to use. And then you see listed here in green is catheter ablation, which is the intervention I do in patients. And this data actually is from 2011. The most recent update now suggests that catheter ablation should be considered as a first-line intervention in certain patients in all of these categories. I have to acknowledge the pioneering work of the surgeons with respect to atrial fibrillation. You will recall when I talked about my time back in cardiology school in Houston, how atrial fibrillation was kind of the ugly duckling in the business. No one paid much attention to it. And this surgeon called Jimmy Cox from St. Louis, Missouri, designed an operation called the Maze operation. And I'll tell you quite honestly, when we first heard about it, we thought the guy was stark raving mad. But his idea, he extrapolated on the information about that multiple wavelet reentry hypothesis of atrial fibrillation, the notion that you need multiple circuits with critical mass to make this thing occur. And he conceived of the notion that if you could compartmentalize the atrial tissue into smaller electrical boxes, then the electrical signal would only progress in one way, and therefore atrial fibrillation would not occur. Of course, that meant, you know, opening the chest, stopping the heart, cutting it up into a bunch of pieces, and sewing it back up together again. But it worked. I mean, he did demonstrate that this could control atrial fibrillation in many patients. However, it's an extensive operation. Over the years, we still do variations of this called the Cox-Maze operation. Really, it's restricted at the present time to people who need an open chest operation for another reason, such as replacing a valve or doing a bypass. So it would be highly unusual to send somebody for this operation to treat their atrial fibrillation nowadays. However, there have been a number of surgical modifications, we call them thoracoscopic mini-maze procedures, that are less invasive than what I'm describing here, that do have a role in the management of atrial fibrillation. But I guess the major development that really has spawned the tremendous evolution of electrophysiological procedures over the course of the last 20 years or so was a paper that was published in the New England Journal back in 1998 by a group out of Bordeaux in France. And they made the observation that for many people with episodic paroxysmal atrial fibrillation, that first phase of atrial fibrillation I talked about, the triggers were coming from the pulmonary veins. The pulmonary veins are the veins that bring the oxygenated blood from the lungs back into the heart, back into the left atrium. And most of us have two of these at each side. Not always the case, but most of us do. And they found also then that if you went in with a catheter delivered through the vein in the leg into the heart and zapped that spot, you could stop the atrial fibrillation from happening. Now it turned out there were some other issues with that, but nonetheless, over the years we have come to realize, and every time there's a variation in this theme, we always come back to the same point, that the key to treating atrial fibrillation is to prevent the electrical signals getting out of these pulmonary veins and going to the rest of the left atrium. So how do we do it if we're not going to use surgery? Well, the technique we use is catheter ablation. This is a relatively, I would call it minimally invasive in the sense that we're doing this through catheters delivered through the veins in the leg, but it's not non-invasive. And we introduce these catheters up into the right atrium. One of them at least will go across into the left atrium. We have to put there's a little membrane there that separates the two chambers that under ultrasound guidance it's very easy to put a catheter across. And the notion then is that you create these, you create these burn lesions around the rim of the pulmonary vein, and ultimately this will translate into a scar, and that scar then will stop the electrical signal getting out of the veins and going to the rest of the heart. And here you see a diagram of how it's theoretically done. Another strategy is something called a wide area ablation. All these brown marks represent ablation signals. And in this case, rather than taking the veins in singletons, we do a big circle around each pair of veins and sometimes do a connecting line at the back. That's called, the more extensive, the longer lasting the atrial fibrillation, the more likely something like this is required. But the technique really that has kind of revolutionized our practice here over the course of the last couple of years is something called cryoablation. I just want to show you a little video of how that works. So here you see the catheter coming up through the vein into the left atrium. Now we're inside the left atrial chamber looking at the pulmonary veins from the inside. And we have this little circular catheter that goes through the center of the tube and records these signals. And we watch these signals throughout the procedure. We'll see these change as the veins become isolated. So over that wire we insert this balloon. This is all happening in the left atrium. The balloon is now inflated and pushed out towards the vein to create a seal. And we verify the presence of that seal by injecting some contrast material. I call this the stopper in the sink. So once we verify the seal, now liquid nitrogen under pressure goes into the balloon. And the anterior hemisphere of the balloon acts like a branding iron, as it were, to freeze the tissue. Tissue gets very cold here. We're down to about minus 60 degrees. And in fact, if you were to be looking inside the chest with a little camera while this is going on, you would see the back wall of the heart form ice. And notice also, I don't know if you can see it now, but the signal up on top here will show a significant change in the electrogram. So this is what we're looking for as we do this procedure. And you can see the little rim here that where we've created the electrical disruption. There have been a number of publications this year about this technology and showing that it's at least as effective as the radio frequency, probably less complications and definitely more efficient. And we here in Sacramento actually have done a substantial number of these cases and have been able to report our observations with the first and second generation balloon. So the first generation balloon, which came out about 2012, the freezing arc was right here, about the center diameter of the balloon, as it were, at center circumference. The newer generation balloon allows freezing across the entire front end, and we find that that's more effective, and published our experience with this recently. The conclusion being that with the second generation balloon, we were able to get the pulmonary vein isolation, that's the disconnection between the pulmonary veins and the atrium, much quicker and with similar adverse events and similar results, but a much more efficient process with the new balloon. Another device that we have worked on and has just recently been released by the FDA is the laser balloon. And with this, again, you were coming into the left atrium. This device, though, has a little camera inside the center of it and a laser source. Also, the balloon is filled with heavy water, so you can actually see the atrial tissue from the inside with this thing. And we deliver these little laser beam arcs of about 15 to 20 degrees and go around circumferentially in the tissue. Now, the nice thing about this is you can actually see the lesion happening as you're doing it. With all the other techniques, the evidence is indirect. With respect to the new developments with radio frequency, the other technique, one of the concerns with the catheter is, how do you know how hard you're pushing? Because the concern is if you don't push hard enough, you won't make contact, and therefore you won't have an effective lesion. If you push too hard, you can puncture right through the wall of the heart. And that causes another set of problems, as you can imagine. And so what some of the vendors have now done is they've been able to put pressure sensors into these catheters, so we actually get a numerical value of the pressure that we're applying on the tissue. So that's some of the new technological developments we have with respect to this atrial fibrillation. So how do we know what patient to select for atrial fibrillation ablation? Who's the best candidate? Well, generally, it's very hard to make people who feel well feel a whole lot better. But for people who feel miserable, we can do much better with that. So people who are very symptomatic, who have tried and failed some drugs, whose atrial fibrillation remains early in the natural history, still paroxysmal, and who tend to be younger and have smaller left atria, these are the ideal candidates. It doesn't mean we can't help the other folks, but these are the ideal patients we have a great chance of getting a good result with. How well does ablation work? Well, the data will show you that for surgical approaches on the top part of the table and catheter approaches in the lower part of the table, you'll see here, in the ideal patient, the surgeons will get it about 70 to 90% of the time. The catheter-based procedures will get it slightly less. But for the, you can't really do multiple surgical procedures, but we can do multiple ablation procedures. If we have to repeat the procedures for our optimal patients, we'll often get it up close to the surgical number. For the less ideal patients, it's significantly less. And if it's a poor candidate, we're down to about the same efficacy as attorneys do, They win half their cases, right? All right, so changing gears now, I want to talk a little bit about the anticoagulation. How's my time? I'm okay, I guess. I can slow down my talking, actually. Yeah.
Another 15 minutes?
Yeah, sure.
So once you've done the ablation, the patient now is in normal sinus rhythm,
Yeah.
and you follow them over a long period of
Yeah.
time, most of these will continue to stay in normal sinus rhythm.
That's an excellent question. And the truth of the matter is we don't really know, because we're not doing this long enough to answer that question. And most of these data endpoints are censored at about 1 year or 2 years, okay? There is no doubt that there is an attrition over time. And a lot of that attrition develops to inadequate control of risk factors, particularly hypertension. So if you have a patient who you've done this to, but you fail to follow control of their blood pressure subsequently, they're at a much greater risk of recurrences over time. So let's talk about warfarin Coumadin. I'm sure everybody here has heard about this drug. A very interesting background story as to how it developed. Back in the 1920s, some farmers up in the northeast of the country noticed that their cattle were dying unexpectedly, and they were bleeding to death, particularly after simple procedures such as dehorning. And somebody was able, this guy Frank Schofield, who was a veterinarian from Canada, figured out that what was happening is that the cattle who died were eating spoiled alfalfa grass. And he was able to do an experiment on rabbits where he took some of the spoiled alfalfa and gave it to one group and gave normal alfalfa to the other group. And lo and behold, the rabbits who got the bad stuff also died. So what was it? There was something in the alfalfa that was causing this problem, right? But it took about another 10 years before the active ingredient was identified, called coumarin. And this is the agent that gives the sweet, sickly smell of new-mown hay or new-cut grass. That's where that smell comes from. And they were ultimately able to isolate the key issue and patented it in 1941. And the reason it was patented by a group in the warfarin corruption in the Wisconsin University, Wisconsin alumni. This is where the name comes from. Wisconsin Alumni Research Foundation, and the Aaron part of it comes from the coumarin. So that's where the name warfarin came from. It was finally approved for human use. It was initially a rodenticide. And one of the ways I get people's attention is, I'm going to put you on rat poison, and it gets their attention. There's a few other things we can do to get their attention, but that in fact is what it was, what it is. First human use then in 1954, and one of the first people to get it was actually Dwight D. Eisenhower when he had an MI. So, that was the drug that we had to mitigate stroke risk for many, many years. And there were a variety of studies done showing that clearly it was effective, much more effective than not taking anything. But for anyone who's been involved in Coumadin clinics or managing care of these patients, you will recognize it is a complete pain. The drug is an unpredictable, performance, a lot of drug and food interactions. You know, if people go on a spinach diet on Fridays and take no green leaves for the rest of the week, we got problems. There is genetic variability in metabolism, and we have to have frequent monitoring of a blood test called the INR. We'll tell you, you know, there's a target INR that we try to achieve. It's 2 to 3. This is the sweet spot. And if you keep people in that range, that's where you're going to be most effective in mitigating stroke risk and avoiding complications. Do you know how often we achieve that? Do we get it 90% of the time? Do we get it 80% of the time? Do we get it 70% of the time? We don't. The fact of the matter is that even in the best controlled studies, with research nurses on top of these patients all the time, ensuring that they get the tests done, about the best that can be achieved is keeping people in TTR, time in therapeutic range, about 66% of the time. Another mantra I have is 1.8 twice the rate. What that means is if the INR drops down to 1.8, you're doubling your rate of stroke. If your INR goes above 3, you're significantly increasing your complication rate, particularly intracranial bleeding. So obviously this gives the pharmaceutical industry a great incentive to come up with some new agents that might mitigate some of these problems and complications. And over the last, I guess, 5 or 6 years, a bunch of these drugs have come available. The first of these is a drug called dabigatran, which acts in one part of the anticoagulation system, and 3 other drugs, apixaban, rivaroxaban, and edoxaban. I'm not going to go into detail about all of these medications. If you watch the 6 o'clock news or those shows, you'll see a lot of advertising for them. If you watch TV at 2 a.m., you'll see a lot of lawyer ads for But all these drugs were tested in major, well-known clinical trials where the comparator was Coumadin was the drug we were using. We knew that was effective, but we also knew it had problems. So all these drugs were tested against Coumadin. They were not tested among each other, so all the comparisons were Coumadin. So rather than showing you bunches of Kaplan-Meier curves showing the various results, I just wanted to give you the summary data where all the information was pooled in a so-called meta-analysis. And let's look what happened with that. So when we pool the information together, we see that as far as stroke and embolism is concerned, the relative risk was now 80%. It's a huge reduction in medical terms, and you see the size of the statistical significance. So we reduced stroke and embolism. We reduced hemorrhagic stroke. We reduced intracranial hemorrhage. A trend towards improvement in ischemic stroke. A significant improvement in all-cause mortality. And a significant improvement in major bleeding. So we get huge benefit in terms of reducing stroke and embolism, and we don't pay a big price in terms of bleeding complications. Now, it's commonly brought up that these drugs are expensive, and there's no doubt that they are expensive, and I'm not going to go into the logic and logistics of pharmaceutical costs and so on. But there have been a variety of economic analysis done showing that compared to Coumadin, these actually are relatively cost effective, something of the order of about 60 to 70,000 per life year saved. And just by comparison, does anyone know what the value of anti-lock brakes are in terms of cost per life year saved? It's 1.2 million. What is the cost of having an ejector seat in a fighter plane per life year saved?
Could you say that again? I couldn't understand you. What is
We're talking about cost. There's a quality metric called cost per life year saved. And the number for these drugs in terms of atrial fibrillation is 70 to 80,000, which sounds like a lot until you compare it to some other things we take for granted. That's about half the cost of hemodialysis. Compared to anti-lock brakes in an automobile, which we assume is something that must be done, that costs 1.3 million. An ejector seat in a fighter plane, that's 22.3 million. So just to put it in economic perspective.
Thank you for the Air Force piece there.
Yeah, I thought you'd enjoy that. All right, so, one of the common misconceptions we had in the past was this, that if we treated somebody with atrial fibrillation and got them back in sinus rhythm, we could just wash our hands and walk away, that we'd eliminated the stroke risk and so on. But we've come to realize completely that that's not the case. And no matter what we do, there will always be a potential risk for return. So the decision now regarding anticoagulation is on the basis of assessment of the big picture. Not if they're in atrial fibrillation at any one point in time, but do they have the propensity for? Have we documented atrial fibrillation in the past? Are we not certain that we have eliminated it completely? And these are the things we want to look at.